Okay, Dr. Berner, I think we can start. And in the beginning, I would like to introduce you and let our audience to know our presenter today. Hello, everybody. Good morning and good evening. I'm PY. Today, we are so happy to have the Dr. Bernard Tansipek with us here online in Zoom at the 33rd ICC webinar here. Today, Dr. Bernard, he received the training at Department of Plastic Reconstructive Surgery at the Philippines General Hospital and been inspired to undergo craniomaxillofacial surgery training in Taiwan. At that moment, because of the lack of adequate service and options provided in the Philippines. Dr. Tansipek is the member and president board of the Node of Craniofacial Foundation, Philippines, NCFP. And he established the NCFP together with our mentor, Dr. Samuel Nodo, and similarly inspire surgeons, dentists, orthodontists, and speech therapists with the goal of providing complete and comprehensive cleft care to all the Filipino children. Today, we are so honored to have Dr. Bernard to come share the topic, multidisciplinary cleft care in the Philippines. Let's welcome Dr. Bernard, please.
Hello, good evening. I'm going to share my screen.
Yes, please.
Okay. All right. Thank you. Good evening. Good morning, wherever everybody is. Happy New Year. Happy Chinese New Year. I would like to thank the doctors, consultants of the Chang Hospital for inviting me for this lecture. I'd like to thank Dr. Lo for especially. It's been more than 15 years since I left from fellowship from Taiwan. Anyway, all right. Just a disclosure, majority of the patients I am presenting here are patients of the Node of Craniofacial Foundation, Philippines, and they have consented to have their pictures presented. And also I'm part of the Board of Trustees of the NCFP. All right. So the objectives of this talk is to discuss multidisciplinary cleft care and to discuss how the NCFP has adapted to enable multidisciplinary cleft care in a resource-poor country like the Philippines. So basically, I just wanted to start with what is a multidisciplinary cleft care. It involves a big cooperation or cooperative involvement of many healthcare disciplines related to cleft lip and palate. So we have the surgeons, the pediatrician, the dentists. I have to stress all different specialties of dentistry because they are essential to our management. The speech pathologist and speech therapist, our psychologist, and our social worker. So what is the cleft burden in our country? In the Philippines, the last study done way back in the 1980s was there was one cleft birth for every 500 babies. So last 2017, there were 1,700,618 babies born. If using that ratio, we have about 3,400 new cleft babies born every year. That's a lot. No? So if you look at this, sorry for this busy slide. This is basically our protocol, our ideal intervention that we use at our foundation. If you look at the extreme right of the screen, as you can see, most of the interventions involve a lot of specialties, not just the surgeon. The surgeon here, the surgeon, the pediatrician, the orthodontist, and then here orthodontist, pediatrician. So you see that the idea that the surgeon is the main person in charge of everything is no longer holding true, because to provide comprehensive or good cleft care, we must involve all different specialties. All right. So not just the intervention, but the timing is essential as well. So I placed here as a reminder that we must educate and coordinate with the parents. Sometimes they forget. I've had cleft patients parents who forget, oh, the patient needs speech therapy. So we must constantly educate, not just not just the parents, but our colleagues as well. So multidisciplinary cleft care actually starts prior to the baby being born. Prenatal diagnosis is essential. Ultrasound, so that usually as early as 12 weeks, age of gestation. However, the studies have shown that the best time to check for any cleft abnormalities is about the 20 weeks age of gestation. And the 3D ultrasound has been shown to be more accurate than just the regular 2D ultrasound. So this is essential because it prepares the parent in anticipation of the child with a cleft, so that they can seek a cleft surgeon or a cleft or a craniofacial orthodontist to advise them and alleviate their worries and help them formulate a plan when the baby is born. Okay, so, and then when the baby is born, the pediatricians come in. So they are usually the first doctors to see the patient. So when I say usually, because in our country, we have a lot of midwives who provide to help the births of our patients. So sometimes it is the midwives who refer to our pediatricians. So, okay, so the role of the pediatricians at this stage is to make sure that they are checked for any cardiac, metabolic, urologic abnormalities, and then later on, as the child is growing, to check for any developmental issues. So when we do our pediatric consultation, the main goal is to prepare the patient for surgery. So what basically to help in feeding and make sure that the mothers realize the weight targets or the nutrition targets for our patients, and of course provide vaccinations for the baby. All right, so right now we have a lot of malnourished patients. We have actually a program with NCF Taiwan where we provide nutritional support for malnourished children, because we have a lot of patients who come in who are very underweight, and definitely they are not good candidates for surgery. So far, our partnership has benefited about 326 patients, and we have improved nutrition based on weight gain from 17% to up to 317% weight gain. So I'd like to thank Linus, who's here, who helps us with our nutrition program. All right. Then, as part of the nutrition of the patient, we have our nasoalveolar molding. So not only does it help reduce the our goal is to reduce the severity of the initial cleft, but it also provides the coverage of the cleft palate so that the patient can feed better. So our nasal alveolar molding, the goal is to have a minimal cleft deformity. So what do we mean by a minimal cleft deformity? So here, I want the lip segments that are almost in contact. You reduce the width of the initial cleft. You provide passive contact to the gingiva. The orthodontist tries to make the alar cartilage as symmetrical as possible. And in the end, there's a better alignment of the lip and nose. So that when we do our chyloplasty, here you can see the results are much better with the NAM rather than having no NAM at all. All right, so nasoalveolar molding, unfortunately, is not covered by Philippine health insurance. So through a cooperation with Smile Train, funding is provided for nasoalveolar molding of our cleft patients, and education and seminars are conducted to teach more dentists in nasoalveolar molding. So we are actually going to have um, a seminar with the Association of Philippine Orthodontists, and they will be doing hands-on training for dentists to teach them how to do NAM. All right, so then we have at 3 months old, once we reach the right weight, we do our chyloplasty. These are basically the NCF surgeons do a modified Millard type of surgery. And then we also do our palatoplasty, usually a 2-flap palatoplasty at around 12 months. So again, because Philippine health insurance does not provide adequate coverage, through cooperations with various foundations, we are able to provide chyloplasty, palatoplasty, alveolar bone grafting, lip revisions, re-repair palatoplasty, facial cleft surgery, and even nasoethmoidal meningocele repairs. All right. This is a bit long because I'm very interested in our dental care for our cleft patients. This is not covered by our health insurance. So the moment the patient finishes palatoplasty, they are immediately referred to our pediatric dentists. And the goal is to take care of the primary and permanent teeth to prevent dental caries and other oral problems. So why is this very important? Because we have seen that if you do not take care of your primary teeth, you will have crossbite issues, malocclusion issues. You will have hypoplasia of your maxilla, as seen in the constriction of the maxillary arch or the mandibular arch. You have to maintain the erupting permanent teeth in expectation of alveolar bone graft, and you have to maintain the primary teeth to help prevent disturbances in the eruption patterns. So again, same here. Dentistry is not covered by our health insurance, but we try our best to, for when the patient reaches adolescence and adulthood, to take care and maintain the permanent teeth, prevent dental caries and other oral problems in preparation for alveolar bone graft and in preparation for orthognathic surgery on skeletal maturity. The orthodontics, again, not covered by health insurance, we must provide, the goal is to provide a functional occlusion, which will help us have good speech, good mastication, and they also help us in our preparation for orthognathic surgery. So here is an example of one of a lot of our cases. We have early loss of our primary tooth. If you see on this patient, this is the incisor, no lateral incisor, no canine, no premolar. This is the second premolar and the molars. So here you have severe constriction of your maxilla, creating a severe, I think in time we'll have a severe skeletal class 3 malocclusion. So this early loss of our primary tooth will cause the arch constriction and the worsening of our anterior and posterior crossbite. Here's one of another patient. She's already an adult. Again, because of the poor dental care, we have severe constriction of the maxillary arch, and we cannot do any alveolar bone graft because there is no teeth that will help support our bone. And again, a lot of dental caries that requires dental rehab. So this is the sequelae of having no health insurance for dental care. Patients have poor dental hygiene. There's an early loss of teeth due to the focus of the dentist is just to get rid of the problem by doing dental extraction instead of restoration of teeth, and they just rely on prosthodontics. For this translated to our pediatric patients, we see almost 90% dental caries rate in non-cleft patients, meaning normal children. And even worse, our cleft patients have an even higher incidence of dental caries. So what have we done? In NCF, we have done a lot of education to prevent dental caries. Here we have our pediatric dentist almost every week. Before the pandemic, they would do this every week, teach children how to brush their teeth and conduct mothers classes. So not only do we teach the children how to brush, but the mothers as well, so that dental care can be provided for. So they are all done on a voluntary basis. We have a cooperation with the Philippine Pediatric Dentistry Center, and their residents help us with the dental care of our patients. And then we have a cooperation with the Association of Philippine Orthodontists, who provide orthodontic care for our patients. Then we have a group of volunteer dentists who give dental rehab and prosthodontic treatment. Okay, so next, once the patient reaches around 2 to 3 years old, we begin our speech therapy. Again, this is not covered by our Philippine health insurance. So the goal of speech therapy is to manage velopharyngeal insufficiency issues, articulation issues, and speech delays. So to answer these issues of lack of speech therapy for our poor patients, we cooperated with the University of Santo Tomas, and their speech pathology interns rotate with us, providing, so it's a double two-way treatment. They learn how to manage our cleft patients, how to give speech therapy for our cleft patients. At the same time, our cleft patients receive speech therapy from the interns. All right. So again, our nasopharyngoscopy not covered by health insurance. So we have already 2 scopes with us, one from NCF Taiwan and one from SmileTrain. So the goal of nasopharyngoscopy is to evaluate speech outcomes after palatoplasty, and to use the NPS as a basis for velopharyngeal surgery when needed. So usually at around 5 to 7 years old, we refer the patients for nasopharyngoscopy. Unfortunately, the kids in the Philippines are not as behaved as the kids in Taiwan, because we've had patients who could not tolerate NPS. Sometimes they are delayed, so up to 9 years old. That's when they have their first NPS. So, yeah. Then we have alveolar bone graft. So again, very important, before we can reach this stage, when we have the patient ready for alveolar bone graft at around 7 to 9 years old, we have to make sure that there is good dental care, that there are no dental caries, or all dental caries have been halted or stopped or restored before doing alveolar bone graft, or we'll end up with infection of our bone graft. So ideally, we perform this at around 7 to 9 years of age. However, again, like this patient, she came to us for lip surgery at around 9, and by the time we had her alveolar bone graft, she was already 12 years old. This is a patient with bilateral cleft palate. A palatoplasty was done at 10 months old, and she has severe maxillary retrusion. So again, the NCF helps in providing orthognathic surgery for our cleft patients. Ideally, around 18 years old to 21 years old. So the problems that we face in our country is that we have a lot of mission cases. So there's either poor repair, the patient is not happy, or there are deceased cases, meaning the surgery was not successful. Then we have our delayed cases. There's still a subgroup of parents who are afraid to have their children undergo cleft surgery. Especially during this pandemic, there were a lot of adult patients who came into our foundation who are not yet have not undergone any palate surgery. Then we also get referred facial cleft cases and nasoethmoidal meningocele cases. So like this patient, he was not happy with his lip repair, and right before he graduated from college, he decided to go on his own and seek the NCF to have his lip repair. So we do secondary surgery. This is a referral from another hospital. So the baby had bilateral cleft lip repair. Unfortunately, the entire premaxilla prolabium got infected, and we ended up with no prolabium. So I had to do straight line repair at the midline, and what remained of the prolabium, I elevated and lifted to create a columella. Then we also have cases of the extrusion of your premaxilla. So here, because I guess the muscle was not repaired well, the premaxilla kept growing forward and tore open the lip repair. So here we had to do a re-repair of our his cleft lip. Then we have delayed surgery. So these are patients who have not had the primary repair. Our oldest patient is this lady. She was already 43 when she came to us. Unfortunately, because she had some medical conditions, her palate repair has not yet been done. But yeah, so 43 is our oldest cleft lip repair. Then we have these patients who are not happy with their lip situation. So we prescribe an Abiflap as a revision for their lip repair. At the same time, improving the posture of their nose. All right, catch-up surgery. So this term I borrowed from Dr. Lim Lei Hui of Penang, Malaysia. I would like to thank her if she's here. Catch-up surgery means patients with delayed treatments needing multiple surgeries in a short span of time, so that they can, by the time they reach, we try as much as possible to finish all the surgeries before they reach 18, or if they're already 18, to make it as short a time as possible so that they can be productive members of society. So it's combinations of alveolar bone grafts, abiflaps, orthognathic surgery, lip revision, and rhinoplasty within a span of 1 to 2 years, so that the surgery can be done and they will be finished with their treatments. Like for this patient, one of our residents performed this surgery a week ago. There is no muscle here in the midline. At the same time, his palate is, there was a dehiscence and it's scarred. So, and there is no, as you can see, no teeth. He's only 22, no teeth at all. So we had to do a furlough to lengthen the palate. At the same time, in the same sitting, we did a revision of his lip repair. I have another case here. She lost her premaxillary teeth, and she was prescribed prosthodontics. However, the prosthodontics caused the lateral maxillary arch to evert upward. And because of the scarred upper lip, it was very difficult for the orthodontist to put in the brackets. So we had to do our Abbey flap. Then she placed brackets, then alveolar bone grafts and orthodontics. For the after which um, we had orthognathic surgery. So it was a two-piece maxilla. We had to fracture the maxilla separately into left and right so that we can bring down and level the teeth. And since she has no central incisors, she has prosthodontics here. What about this lady with the very poor dental hygiene? So we did orthodontics, then orthognathic surgery, then an Abbey flap to fix the upper lip, and prosthodontics. So this her maxillary teeth are actually prosthodontics. So we have also, so this is an example of our catch-up surgery. When she came to us for ABG, alveolar bone graft, she was already 16 years old. But nevertheless, we still continued with an alveolar bone graft to unite the left and right segments of the maxillary arch. Then we proceeded with orthodontics, then orthognathic surgery. Then after a year, a lip revision with rhinoplasty using ear cartilage grafts was done. Okay, so what about part of the NCF is because is our focus on facial clefts, because we are a tertiary referral hospital. The Philippine General Hospital is a tertiary referral hospital, and we get a lot of the facial clefts from the outlying provinces. So one innovation I think that I must credit our orthodontists is they were able to do nasoalveolar molding for one of our facial cleft patients. And here. So for our facial cleft surgery, I usually perform rotation advancement. This was described by Dr. Kawamoto in his journal, so that all the incision lines will be along the aesthetic units of the face. Like here. So these are some of our facial cleft patients. So as you can see, the scars are along the aesthetic unit, so that the cheek area will be free of any Z-plasties and it will be more aesthetic. All right. And then we also have our patients with the facial cleft who underwent orthognathic surgery. She's a facial cleft 0. So after repairing the facial cleft, we did orthognathic surgery and rib cartilage graft rhinoplasty. We have a lot of nasoethmoidal meningoceles. It's a failure of fusion of the frontal bones, and you have the brain coming out. So I think it's part of the sequelae of the facial cleft number 0, number 14. So with NCF's partnership with the Philippine General Hospital, we set up the pediatric neurocraniofacial operating unit to take care of our nasoethmoidal meningoceles. And so far, we have done about 120 cases. He's one of our earliest cases. She sent me this picture after she graduated from college. So she had intra and extracranial repair, and after a year underwent rhinoplasty with rib cartilage graft. So this is one of our facial cleft patients with cranial extension with the meningocele. So it's a facial cleft number 4, number 10. Here we see this is a split calvarial bone graft that we harvested from this parietal area and placed it over the cranial defect. And to close the meningocele. All right. Here we go. All right. So the NCF also provides social services or transportation for our patients, because at the start of our foundation, you notice that the patients, especially the very poor ones, did not have money enough to be brought to our center, and they would rather spend the money that they have on food. So we have a compromise was made wherein we would meet them halfway and provide, and our follow-ups actually rose. No? So far, that our transportation service has benefited about 3,727 patients. Then we also set up our family support group. So this is very important because a lot of our patients and our parents don't know what to do when it comes to care for their cleft patients. So the older mothers and older patients actually advise the younger ones and providing counseling. At the same time, our social service staff helps teach the older patients and older parents how to provide the counseling for the younger ones. And for our adolescent patients, the NCF helps them try to get back and become productive members of society. So the last time there was a career workshop for our parents with trainers from different companies, and teaching them how to write a resume and how to do job interviews. So what else? Also, for our younger patients, the NCF and the family and patient support group organize workshops such as painting workshops, so that to help them socialize with and gain confidence. And finally, a few years ago, the members of our patients and the family support group decided to give back. So they visited the Asilio de San Vicente de Paul orphanage, and this time they were not the receivers of care, they were the givers of care. So they were helping all these orphans, some of them who had gone through surgery, trying to cheer them up and have a good Christmas. So yeah. So I think the multidisciplinary cooperation is very important, especially with all specialties. Our goal is to enable our cleft and craniofacial patients to integrate into society and help them achieve success in their lives. So part of this is NCF always tries to educate the public on comprehensive cleft care. And of course, one of our projects is this one. We try as much as possible to stand up against bullying. This is a Facebook post of different Filipino celebrities or actors, and they placed cleft lips on them. So the mothers are actually the mother support group set up some sort of message Facebook to take down this post. So yeah, it's one of our problems. There's still a lot of bullying among our in our society for cleft, against the cleft patients. Yes, thank you. I hope if there are any questions, I'll be glad to answer them.
Thank you so much, Dr. Tansipek, for your brilliant lecture. I think we all learned a lot about the current situation in Philippines, and also on your cases and how you dealt with them, and also congratulate you on the great outcomes that you achieved. And also, for our first speaker, I would like to invite Professor Loh for a few comments.
Hi, Dr. Bernie. Thank you for your presentation. It's wonderful to see the hard work that you're doing in your hospital and also in your society. And I feel that it's actually you have more difficult cases than we have here in Taiwan, because you see many of the patients who receive poor surgery that resulted in for example palate or dental alveolar arch constriction and very scarred palate and very bad lip and nose, and you have to do secondary surgery, and these are all very difficult cases to us, you know. And I saw your result, really nice. I appreciate and thank you very much. Now I would like to discuss with you several issues. I think the number one is that you reported that a lot of surgery has poor outcome, poor result from other surgery. I don't know who did the surgery and they come to you. And can you do something that, for example, some kind of message in the society that whoever surgeon when you are doing the surgery, you have to be careful. Otherwise, you refer the case to your service to PGH instead of doing surgery when you are still not familiar. Can you answer this first issue?
That is a very very difficult issue, because there are a lot of specialties doing cleft surgeries in our country, and there is no, because the medical rules and medical laws are not very strict, so it allows a lot of different doctors to do surgery. So what we usually do is on the part of NCF is to educate the recipients of the care, like the parents, the doctors who refer to us. So these are the two. That's why I always try to give these lectures to starting from the level of the medical students all the way to the specialists like the pediatricians, so that they will understand that the concept of cleft surgery is not just you do lip repair and palate repair and you're done. This is the problem, I think, where it all stems from, because in our country, the concept of a continuing care from childhood to adulthood is still not yet ingrained into the society. Even some of the doctors, I've had referrals from a pediatrician who told me, I'm referring you a patient who's 10 months old and 10 something something because of the rule of 10. I said 10 months is too late. And, anyway, so I still have to keep on educating. I think that's the only way to go forward, is to educate. So we have actually, again, I would like to thank NCF Taiwan, because they're helping us by we have a social media person in charge of this, so they always provide YouTube or Facebook posts so that the mothers will not be confused on what to do. So yeah. So
okay.
yeah.
The second issue is that again today I saw the complication of the bilateral credit repair with dehiscence, which is quite common whenever I went to some surgery collaboration missions. I saw such cases. Well, maybe in your hospital you have orthodontists to help you to do nasoalveolar molding. But however, this case, there are some of these cases may go to other inexperienced surgeon, or for some surgeon, if they do not have the molding surface, what do you suggest for the bilateral cleft lip repair? With very protruding premaxilla.
Yeah. So for the Philippine General Hospital, we try as much as possible to have a protocol to, like, we try, I've had some patients that more than 3 months old that I try to convince our orthodontist to do lip taping and try to bring back the premaxilla. But usually after 5 months, they tell me it cannot be done. So an option would be, I think sometimes we have to do our premaxillary setback. Yeah.
Okay. Then the next issue is the you mentioned catch-up surgery. Okay, this is for patients who came to you late in their life, maybe still unrepaired or maybe repaired by other surgeons, but very poor result. Now, for example, if he is now 9 years old, with many situation that you have to deal with, do you have a protocol to for this kind of catch-up surgery, or you set up your planning case by case, or you have some protocol for this group of patients?
Okay. The main problem for those catch-up patients, we try, it's a case-to-case basis. So for example, when they come to me, you always have to see them together with our dentists. It always comes hand in hand. So that's why usually when I have a clinic, the orthodontist or one of the dentists is also there, so I can just hand it over. We have to make sure that there are no dental caries and you have good dental care. So that's our first, because if ever we have to do any palate surgery, alveolar bone graft, and the teeth is needs dental rehab, you end up with infections. So that's our number one issue. Dental care the dental condition must be good. Then you usually always have to make sure that the speech is good as well. So for example, 9 years old, there's a palatoplasty has been done. So they will then undergo nasopharyngoscopy. From there, we can stage the planning of the surgery. Usually, in most of the cases of delayed cases that I end up with, I have to do the alveolar bone graft and the furlow or pharyngeal flap or palate re-repair in one sitting. So we do the palate re-repair or do the furlow, then do then do the bone graft, so that we save one surgery for the patient. Then afterwards do the lip. But there have cases that I have to do an AB flap first if the lip is really bad and it will not hold the bone graft. Then I have to do the AB flap first, then do the other surgery. So it's a case-to-case basis depending on the need of the patient at the time.
Yeah, actually, for patients with very badly repaired cleft lip deformity, AB flap seems to be a good solution in several situations. And this maybe is a good information for other people. And then I remember that years ago I visited your country and you told me to visit your hospital PGH, and I saw many craniofacial cleft. And you mentioned today that you have 120 cases with 014 Tessier. Is that true?
It's the nasoethmoidal meningoceles.
Yeah.
Since we've already performed about 120.
20. Yeah, that I think that's a lot. I think maybe in addition to Thailand, maybe you're one of the center who perform such many cases. I think you should collect all the cases and do a report and write a paper?
Oh, yeah, actually, Dr. Dax and Dr. Denadal already did with me. We
So it's
already
a job
published
of
it.
Dr. Dax.
We already published the paper. No, he was, because when he was our resident, he was very interested in that subset of patients. So we set up, yeah, we already have a paper on that.
Okay, thank you. Very good job. Thank you again.
Thank you, Dr. Lo.
Okay, now we'll go to the Q&A section. And first question is from Dr. Jaquino, and he would like to ask you, what are your thoughts on doing a combined cleft lip and palate repair in one stage instead of doing it in 2 stages for third world countries?
Okay. I only recommend doing two what we call simultaneous cleft palate then cleft lip surgery in one sitting if there must be a criteria, because the patient's blood conditions such as hemoglobin and hematocrit must be high enough, because sometimes the palate repair can be quite bloody because these are older patients, right? So number two, if there is really a contraindication or an issue where the patient cannot come back for the second surgery, then we might consider doing a simultaneous palate and lip repair. Yes, we've done it for, especially in our center where we have patients coming, like it takes them 1 to 2 days just to get to the hospital, or it's quite far. But that's lately in our country, it's becoming less and less, but it can still happen. And I think if you really have to do the one sitting simultaneous surgery, I always ask the patient, even the foundation, have we exhausted all our resources that the patient cannot follow up with us and we have to do this simultaneous surgery? Only when there is no other recourse, then I would. But if there is a way where we can help the patient follow up with us, I wouldn't put the risk. But yeah. So again, it's a case-to-case basis.
Okay, thank you. And our second question is from Dr. Jamar, and he would like to ask you, how did the COVID affect the delivery of the services of NCF?
All right, that's a very good question. Definitely because of COVID, there were months that we had no surgeries. And right now, our pediatric anesthesiologists are very, very afraid, so that we only get to do about half or even 1/4 of the volume of cases that we used to do. So right now we have a lot of backlogs. Definitely. The problem here is to be able to have the surgery done, we have to do a swab test for the child and the guardian. If the guardian becomes positive, even if the child is negative, the surgery is canceled because that's an exposure. So yeah, and with the recent Omicron variant, I've had 4 cancellations in a week because either the mother is positive or the father is positive, and we have to cancel the surgery.
Wow.
There was even one father who got mad at me on the phone that, how come my child is positive? She doesn't go out, she's a baby. And I said, look at your results. You're positive. It's come from you. It came from you.
Okay, and then our next question is from Dr. Cruz. He would like to ask, in the Philippines, where access to specialized surgical care is sometimes very difficult, do you recommend surgical missions in geographically isolated and disadvantaged areas, or would you recommend another good alternative program?
Okay, so what we are doing now in NCF is we're trying to expand our services so that the mission system can be a thing of the past. I think the mission system in the Philippines was like it's like a band-aid. So, for example, if you have a wound, you just put a band-aid on it for the meantime, while you're on the way to the hospital until you get it sutured. So during the past, we had a lack of specialists. So right now, there are increasingly more plastic surgeons who are well trained. So like Dr. Dax we're starting a branch of the NCF in Davao, which is, sorry, the southern part of the Philippines. And we're also trying to start a relationship in another city in the middle of the Philippines to start another craniofacial center. So I think so the work of the foundation is to help those patients who are who are from far-flung areas to get their services done. So at the start, if I would just like to talk about the history of NCF Philippines, when we were starting out, we had relationships, tie-ups with companies like the Philippine Airlines. So if the patient comes from very far, some of the passengers would donate their miles, and these miles would go into the transport of the father or the mother and the child. And then we've got into partnerships with halfway houses, meaning wherein the patients can stay while waiting for their surgeries. So if you really want to set up a craniofacial center, I think it can be done, but it takes a lot of work, so that when the idea of a mission in far-flung areas might be slowly not needed anymore in the future. So I think that's the goal of what we're trying to set up the NCF, is to try to one, educate everybody that cleft surgery is not just chyloplasty, not palatoplasty, and it's over, because you cannot do speech therapy on a mission. You cannot do dental care or orthodontics on a mission setting. So maybe it's like improving ourselves. So we used to do missions. Now let us improve the way we deliver our services for our countrymen by setting up craniofacial centers. I think it's the next step.
Okay, thank you. And Dr. Hongda would like to comment that he's very impressed with the patient support system from children to adult patients. But he was wondering, is that volunteer based, and how many patients or parents are involved in the supporting system?
A lot of the support system is volunteer based. So right now, I don't really know the exact number. I think we have a core group of about 15 parents and about, I think, 10 patients. And then slowly we're trying to get them more involved.
Okay, thank you. And that's it for our question and answer section. So we would like to, at this time, invite Dr. Chang to give us a few comments.
Hi, Bernie. Long time no
Hi,
see.
Frank.
And I think 15 years ago, he was in our center. I met him. He is a very hard worker, and he really have that kinds of interesting and everything. And congratulations, a very good job and very good result. And also I meet him in several international meetings. I can see his hunger for sharing experience and looking for newer techniques. I have one question. So when I have cherished missions on Philippines, I noticed that it's also in Vietnam. I noticed many patients are underweight. Their pre-surgical condition is not very well. And also their post-operative wound care is not very good. especially on second day, I can see some patient, the wound is covered with blood, with mucus, with everything mixed out there. And also, it's very difficult to educate the parents for and Bernie, I saw you get a good result. How you deal with those problems?
Okay, that's the main issue that we always have to deal with, because a lot of the patients during missions are actually those who have are what you call the class CE, or the very poor patients. So they're very malnourished. So that's why we have a very close cooperation with our pediatricians. It's actually the result, the poor wound condition is the result of the poor nutrition of the patient. If you do not have a good nutrition, you create a wound, and definitely wound healing will be a problem. So we have our pediatrician, our hardworking pediatricians. They have a criteria that sets that even if the child is 3 months old and the severe underweight, then surgery has to be deferred, will not push through. So we see this often in our uh, uh, young mothers, because we have a lot of teenage pregnancies. So very young mothers who really don't know how to take care of and nourish their children. On the case of education, yes, common practice for me is I will do the cleaning of the wound the next day and show it to the mother. Then I will say, okay, now it's your turn. Then sometimes I ask them to return what you call a return demo, or I have the nurses say, show them how to do it, then watch if they can do it properly. It's patient education is the key, I think. That's why the mission system is very hard to make it work, because you cannot educate them on a short term. It has to be a continue. It's like reminding somebody to, you have to do this, you have to do this. Yeah, I hope I answered your question.
Yes, thank you. Yeah, I have no more questions. And I think we have later on group photo, and if we have time, I will borrow you 3 minutes to introduce our this year's forum, Tongan forum on October.
I think, can I just have one last comment?
Or Dr. Zhou? Yeah.
Can I have yeah.
Yes,
I realized while setting up this craniofacial, the NCF, is that I had to study or know dentistry so that I can integrate. I had to know speech therapy. I even when I was in Chang, I went to the nasopharyngoscopy sessions with Claudia and Ruby. So just to see how it's done so that I can understand how to set it up. And I also went with Dr. Huang to see how he does. What do I need to learn for orthodontics? So yeah. So I have the joke I always tell my dentist, oh, I'm a dentist, it's my hobby. I have a I'm a part-time dentist. So.
Yes, no worry, Dr. Bernie. This video will share with all your previous colleagues in Chang'an, to Claudia, to to Dr. Wang as well. Okay, Professor Frank Chen, please go ahead.
Dr. Chang, I don't think your microphone is on.
My microphone not on. Okay, let me.
Now it's on. Now it's on.
It's on.
Yes.
Okay. Sorry. Can you see the PowerPoint?
Yes, very well.
Okay. Hello, friends. I see many friends here. So please save in your October 29 to 30 to us. This is our coming Chang Forum. This year, the topic is credit and palate repair. Of course, we will cover nasal alveolar molding. On the primary chiroplasty, the most frequent practice worldwide are Tennyson, Miller, Moller, Mulligan, and Fisher. Currently, our center, we have Professor Low using Miller, myself, I using Moller, and Dr. Lu, when she came back from Toronto, she's using Fisher. So we are covering this year the 3 most frequent methods in the world. And of course, you will be step-by-step using video demonstration, step-by-step, teaching how is the difference of three technique. This is the first time we have comparison 3 technique. In brief introduction, this is a so-called traditional molar with a backup there. This is after surgery. And Professor Low using Mila. Of course, I learned something from him. So this is one of my patients. And this is Mila without backup. And this is after surgery. This is the outcome. And this is Fisher when Dr. Lu come back from Toronto. And in difference the traditional backup, this is a design for the Fisher, and this is the design. This is after surgery, and you can see the surgical design is different using the concept of the unit of upper lip. Of course, we will cover bilateral chiroplasty and also palatoplasty. The palatoplasty is shifting from the old time traditional 2 flap with muscle reposition to right now we will incorporate 2 flap. On the posterior side, we will incorporate the opponent G into soft palate. And of course, the bigger G or smaller G, and it will well explained on the foreign, and also the roll surface created, the 2 roll surface before using surgery cell. Right now we're using Bacofat pad, and it will cover also the BPI diagnosis and the surgical management of BPI. Even though we have very few cases of BPI each year right now. And then we also will discuss with APG the 3D CT evaluation of the defect, the study of defect. And right now we incorporate the newer bone harvest. Traditionally, we harvest the iliac bone. We need 3 centimeter incision, split the iliac crest into 2 halves and harvest chiral bone. Right now we use trophy, only a small, very small hole. The wound is even half of the wound size. And you can see this is day 1 after surgery. The patient can already walk. And this is 1 week after surgery. You can see he can jump. He can jump very well. And also orthodontic surgery, we have shift from 2 spring to 1 spring technique. 1 spring is very technical demanding. But currently we incorporate the CAT scan, and the two spring will be fabricated with 3D computer printed. And right now the accuracy is very well, so we don't have to worry about a single spring. We just do the surgery and the final checkout, and this is the 3D with maxilla advancement and the mandibular setback. And with 3D, you can see where is the overlapping area, measure how much is setback and how much the maxilla will be advanced. The final will be cover the secondary cleft lip and the nose repair. And the lip repair, we can do the lip repair, reopen the wound, redo the muscle position, and create a good central dimple and the cleft side projection. But what is the alternative? We can do a simplified injection or hair follicle transplantation, and we will cover this. And what about nasal dosing? Currently in our center, we have rib cartilage, ear cartilage, or dermal fat for nasal dosing. For the tip projection, we can use ear cartilage. We can also use rib cartilage, and the difference will be covered well on this new Chang forum. And right now we are doing more video recording, and you will cover step by step, and each clinical clarify our technique in each. And you can also ask questions during forum, and the difference between the two technique or three technique. I think it will be wonderful that we cover most of different technique in the world. And also this time we will also have microsia and the hemifacial microsomia incorporated. So far, this is our preliminary program. So far is not set yet, but I think this is the basic of our forum. And we are waiting to see you on this 12th international workshop. Thank you, everybody.
Yeah, thank you, Professor Frank Chang. Thank you for your sharing about the very important information with our audience in Chang Forum. Yes, and thank you, Dr. Berna, for your wonderful presentation for our audience this evening. Thank you very much. With your very educational and comprehensive presentation. And I would like to invite all our participants to show your beautiful smile. I would like to invite you to come join with us, have a group photo with our presenter, Dr. Berna. Okay, yeah, come on. Yes, yeah. Today is our last day of Lunar New Year's, the holidays in Taiwan. Tomorrow is our first day. We will start our new beginning in our work day. So actually, I would like to tightly to hang on the very, very luxury timing with all our audience here, because we have to work very hard tomorrow. Yeah, so thank you for your join with us tonight. So later I will count to 3 and please show you a smile with me and with the Professor Berna as well. Okay, I will count to 3. So I say 1, 2, 3, please show your heart, or you can give me a very triumph gesture as well. Okay, 1, 2, cheese. Thank you very much. And I would like to move to the page 2. Okay. 1, 2, cheese. Thank you very much, all my friends in ICC. And the third page. 1, 2, cheese. Thank you very much. Yes. Okay, thank you, Dr. Berna, again and again. Good morning and good evening. Our next ICC webinar will be held 2 weeks later. And the presenter is Dr. Shibin Chao. He is a renowned craniofacial and cosmetic surgeon in Taiwan. He ever been our member in Chang Memorial Hospital as well. So looking forward to see you 2 weeks later. Good morning and good evening. Thank you. Bye-bye. Thank you, Dr. Berna. Thank you very much.
Bye-bye. Happy New Year.
Happy New Year. Thank you. Thank you. Yeah. I really enjoy your talk for the Filipinos, the models in the Cleft care. Yes.
Oh, thank you.
Thank you. And I hope to see you in person in the future.
Yes. All right. Same to you. Same. I have to go get back to Taiwan.
Yeah. I would like to visit Tex and you and Faye as well in Philippines.
Oh, yes. That's great.
Okay. Have a good night.
Okay. Bye-bye. Good night.
Bye-bye. Bye-bye. Thank you, Junior.
Thank you.
Thank you very much.